Dr. Sabyasachi Sengupta, the founder and chief medical director, lead biostatistician of Sengupta's Research Academy. He'll be talking to us on evolving retinal services in the last 10 years in India. He has a lot of experience in writing a whole lot of papers, especially with relation to population-based statistics. So he would be the best person to tell us as to how we have evolved, where we stand currently, and I think also our way forward, which is not definitely going to be easy given the increasing numbers of diabetics in the country.
Thank you, sir, and very good evening to all of you. And I thank AIOS for giving me this opportunity on this very important day for us. So I thought I'll quickly share with you some snippets on how retinal disease management has evolved over the past decade. Say where we were in 2010, how we have now evolved into the way we treat, and where we are really going in the future. So I'm Dr. Sabyasachi Sengupta. I'm primarily a vitreoretinal surgeon practicing in Mumbai, and I also help people do research through my research academy. So overall, I thought because we've already talked so much about prevalence of disease and diabetic retinopathy by Dr. Chaitra, which was really nice and succinct. I thought we'll dive slightly about, or we'll zoom out and look at more in terms of what other retinal diseases are sort of prevalent, how we have defined them, and how we have learned and moved forward. So overall, I thought, there are newer disease entities which have now emerged, and, we are seeing more and more of these entities, and there is better understanding, and I'll show you some examples of these. There are many newer diagnostic modalities, and many of them essentially have thrown in a lot of biomarkers, and, how we use this in terms of disease, diagnostic, treatment, and prognostication is also something that we'll discuss. There are many newer treatment regimens which have come across, how frequently we give treatments for different retinal diseases. So we'll discuss a bit about that. Then, of course, there are many newer molecules which have come in, and anti-VEGFs are getting better and better. So we'll take a quick look at what new anti-VEGFs are there and in the pipeline. And then I thought we'll share a little bit about some future trends of where we are going. So this is my editorial in the IJO in December 2018. That was a special issue on vitreoretinal diseases, and you might want to take a look at some of that because it will be a succinct read, and a lot of what I'm going to talk now is taken from that. So there are many newer disease entities that we have now well defined. Primarily, the commonest that we now see is something called polypoidal choroidal vasculopathy. It was quite an enigma when I was doing my training way back in 2010, but now I think we have really well characterized this disease. So we'll talk a bit about that. There are some other entities like focal choroidal excavations, peripapillary pachychoroids, dome shaped macula, and some others. I'll show you some examples. So polypoidal choroidal vasculopathy is really a distinct form of neovascular AMD. You can call it a close cousin, but it doesn't always respond to management like the way neovascular AMD responds, and the chances of occurrence or recurrence in the same and other eye are much higher than neovascular AMD. ICGA or indocyanine green angiographies really helped us characterize it in terms of the lesions are seen as hotspots, and there are something else which are called branching vascular networks, which are also seen. OCT, you see tall tented PEDs with notches. I'll show you some examples. OCTA, I think, is still evolving. And the Everest and Planet studies are the ones which have really given us, how we treat this. And we are gradually gravitating towards anti-VEGF monotherapy, especially with newer and potent anti-VEGFs emerging. So this is a copybook case of polypoidal choroidal vasculopathy. As you can see, this is the ICG where you see this hotspot, and this is the other eye where you see hotspots. And these are the tall tented PEDs and PEDs with notches, as you can see the arrow here. So this is a classic example of polypoidal choroidal vasculopathy. If you see this, it's important to discuss with the patient and the sort of response to therapy, need for better agents which are deeper penetrative like aflibercept. Now we have brolucizumab, and chances for recurrence in the same and the other eye also have to be discussed. And this has now come into picture is the term called pachychoroid, which means just a thickened choroid, and in the Indian context it's about 370 to 400 microns thick. And so PCV is part of the pachychoroid spectrum. The other so the overall spectrum consists of central serous chorioretinopathy, pachychoroid pigment epitheliopathy or PPE, pachychoroid neovasculopathy, and PCV or polypoidal choroidal vasculopathy. So this is something that has gradually evolved over the last decade, and I thought I sort of bring it out here. And like I said, the PLANET study has clearly shown that aflibercept monotherapy is quite excellent compared to aflibercept with combination of PDT and aflibercept. So we are gravitating towards treating these with monotherapy. Other examples of newer disease entities, something called focal choroidal excavation. We don't know whether this is a cause or the effect of diseases, but these are, so you can see this excavated so RPE, which just dives down or nose dives and then comes back. So these are some examples of focal choroidal excavation. We're still learning new about many things about this, and this is seen in multiple disease entities. There is something called peripapillary pachychoroid, where the thickened choroid is just on the peripapillary area and does not involve the rest of the macula. And this is another case where another new entity called bacillary layer detachment is seen, that is splitting of the deeper retina or the outer retina at the junction of the junction of the external limiting membrane and EZ, or basically between the ellipsoidal and the the ellipsoid and the layer of the photoreceptor. So this is something again which is coming up, and we are seeing it in many disease entities. There's something called the dome-shaped macula seen predominantly in high myopes, and you will see CSR-like picture, but actually the causative, you will not see any leak on the FFA, and this is because there is a dome-shaped macula, generally self-limiting and goes away. And some other entities called peripapillary choroidal cavitation, where you can see this basically mimics glaucoma, and a lot of people keep getting glaucoma medications, but generally the OCT is quite characteristic in the terms of huge cavitation below the RP in the peripapillary zone, and this is again generally seen in high myopes, should not be confused with glaucoma. So, these are some of the newer disease entities which have emerged over the last decade. There are again newer diagnostic modalities. So spectral domain and now swept source OCT help us see deeper and better. Multimodal imaging in terms of tricolor, fundus autofluorescence, infrared imaging have also helped us understand a lot of these diseases. Wide field imaging, so now you can actually see aura to aura with 360 degrees using many wide field imaging cameras. A lot of them are non-mydriatic as well. OCTA or OCT angiography, adaptive optics, these are all coming in. I'll show you some examples as we go along. And automations in imaging, which are going more and more smartphone based cameras, and automated detection of diseases really coming in a big way, like Dr. Lalit was telling us a little while back. And so there are new, when we do newer OCTs, we start looking at disease entities, and there are new biomarkers which have emerged. Some of them are hyperreflective foci, choroidal thickness and vascularity indices are coming up now. And there are other entities called ORTs, drill, STEM. So I'll show you some examples. These are examples of hyperreflective foci. As you can see, these small dots in the inner retina, sometimes in the outer retina, and also now in the choroid. These are bad prognostic markers for diabetic macular edema or vein occlusions. A lot of these patients may need more anti-VEGFs, and it is recommended that you consider steroids much earlier than stick to anti-VEGFs when you see hyperreflective foci. ORTs are outer retinal tubulations, and drill means disorganized retinal inner layers. Again, these are poor prognostic markers. As you will see, these are drills. So, this is different. These are different from cystoid macular edema, and this is an example of a drill where all the inner retinal layers are disorganized, and these patients may have vision of 660 or 636 at the most, and you will say, why do patients have very poor vision? But then the central 1 millimeter may have entire disorganization, and that's called drill. Another biomarker is called SHREM, that is subretinal hyperreflective material. As you can see here, this mound, which is again, so this is above the RPE. So this is again a bad prognostic sign in neovascular AMD, and these patients end up doing quite badly and have some scarring. Again, multimodal imaging in neovascular AMD has emerged in terms of color fundus photography, angiography, autofluorescence, indocyanine and green angiography, OCT, and OCT angiography. So these are all the new things that have happened over the last decade. And there are recent advances in terms of how we are looking at OCT, and we are not looking at OCT in terms of microns, but in nanoliters. So this is a quick video to show you how all the fluid is being detected at different layers, and then you are all collating them on the 6 by 6 millimeter central scan, and then you are categorizing fluid in terms of nanoliters. So So these are some some results from some recent clinical trials where you see fluid is in nanoliters. We're not going to go into the details of this. So this is intraretinal fluid, this is subretinal fluid, and this is sub-RP fluid. All of these are in nanoliters. So this is, I think, something we are going to watch out for in the next year or so, where a lot of machines will give us fluid in terms of nanoliters and not microns. And disease activity could be characterized in this manner, where high intraretinal fluid of say 12 microns, high SRF of 60 microns, and high PD of 443 microns is high disease activity. Low disease activity is so 0.4 nanoliters. It's not microns, sorry, it's nanoliters. So it's really small. So some of these measurements might be cut off and tell us whether the disease activity is high or low, and then how we might treat them. There are certain newer treatment regimens which are coming in. So we started with monthly injections of anti-VEGFs. Then we moved over to PRN regimens. And now where we are is treat and extend. So in treat and extend, there are many clinical trials now which support this. What we are doing is extending treatment. What we are doing really is extending treatment, but injecting at every visit is irrespective of disease activity, and the duration of follow-up is being extended by 2 weeks at a time. We have also learned from these clinical trials that intraretinal fluid impacts vision the most, subretinal fluid slightly less, and sub-RP fluid probably it impacts the least. So, fresh, persistent, or recurrent intraretinal fluid will have worst visual outcomes. Foveal intraretinal fluid is definitely worse. Subretinal fluid may be tolerated, may even be slightly beneficial in the long run, and sub-RP fluid, we are still evolving in how we are understanding that. So the whole concept in AMD is in overall in terms of fluid, where fluid in different compartments have different impacts on vision. Like I said, lower variations are associated with better vision. Also, updates really show that zero tolerance fluid approach is beneficial. So I think that is something we need to all aim for. Inclusion of newer generation anti-VEGF armamentarium drives fluid better, and a lot of development of AI-based fluid assessments are there, like I've already shown you. Some newer molecules which are there, ranibizumab and its biosimilars is already we had. Aflibercept is there for the last 5 years or so. Now we have brolucizumab. I'll quickly show you some results where brolucizumab was compared to aflibercept in the phase 3 clinical trials. They did equally well in terms of how vision was improving, but fluid drying ability was better with brolucizumab than with aflibercept. So, the overall need for re-injections is what we're looking for. 50% needed re-injections every 3 months, and the rest needed every 2 months. This is again much better than what we already have, currently. And anecdotally, many are doing well even 4 to 5 months after the first injection of brolucizumab. So, definitely a step ahead in terms of reducing the treatment burden of patients. And in the pipeline, there are longer acting drugs. So this is the port delivery system, which will be placed subconjunctivally, and this is how it will look. This is behind the lens. And you can fill this device every 6 months with 100 micrograms of 100 milligrams of ranibizumab, and it will keep releasing for 6 months. Now, there are many new molecules. So bevacizumab, aflibercept, and ranibizumab is something that we are already using. Conbercept, brolucizumab, abicipar, Pigol, and there are many more in the pipeline. And the one that I'm really excited about is called faricimab. It might be available in our clinics in about, I think about a year or year and a half's time. And we won't have enough time to go into the details, but this is the name that you might want to remember. There are future trends in terms of OCT, angiography and its expanding applications in diagnosis and activity, adaptive optics and its applications in retinal diseases. So OCTA, what we are really doing is segmenting the superficial plexus, the intermediate plexus, and the deep capillary plexus, as well as the choroidal plexus. So all machines vary significantly in how they do this segmentation. These are the machines that are available, where you have AngioView, AngioPlex from Zeiss, Spectralis OCT from Heidelberg, AngioScan from Nidec, and Sweptsos OCT from Topcon. So all of these are doing the same job in all different manners. And like I said, these are all the scans from different machines on the same patient, which are showing slightly different results. In AMD, this is how the sort of scan looks like, where pre-injection you will see a large plexus. This is the OCT angiography on top, and this is actually a demonstration, just a cartoon at the bottom. This is how it shrinks at 1 week, and then at 4 weeks these rugosities sort of keep coming back. So this is an indicator of disease activity. Adaptive optics, you can really actually see photoreceptors in vivo, where so these are some examples from recent review in British Journal of Ophthalmology. So these are some cones and rods in a normal patient, and these are some cones and rods in a patient with retinitis pigmentosa and other cone-related disorders. So you can actually see, these almost 2 microns resolution, and you will be able to see almost inside the cone. So this is something very exciting to watch out for. And there are some important clinical trials that I thought I'll quickly enlist, where the DRCR.network is, of course, the most important for diabetic retinopathy. It has about 20 arms already, and then many more which are coming up. So this is really redefining the way we treat diabetic retinopathy. The ARIES and ALTAIR are the recent trials which show aflibercept works very well in treat and extend protocols for neovascular AMD. And so I think in the future, we are going to use treat and extend as the most important sort of protocol for treatment, irrespective of drug we use. And the PLANET study has shown us that the aflibercept or anti-VEGF monotherapy is pretty good in terms of managing PCV. And Hawker Harrier trials are the ones which have shown that brolucizumab is really effective in neovascular AMD. So these are some of the I think this is how it has evolved over the last decade or so. Of course, there are many other things such as gene therapies and how we treat infections in others, but we don't have enough time to go into the details. So I thought I will quickly touch on how it has evolved over the last 10 years or so. Thank you very much. I can take questions now or later.